Hello, everyone. We will be reviewing the urgent care process today, and this is Group 5 presenting, where we will walk you through the current walk-in clinic process for the patients and how we propose an improvement in that process. Now, we'll first review the agenda, what we plan to cover in this presentation. Healthcare institutions generally use an appointment-based system. However, patients often need to review medical services unexpectedly. If they visit a clinic without an appointment, then they have to wait for a longer time. And we have probably seen that this wait is somewhere around 1.5 hours to maybe even 2 hours. Now, in this study, we investigate whether the clinical registration system can be improved by separating the queues and resources for our different type of patients which the clinic sees. Now, in this presentation, we have a systematic approach on how we can reduce the patient's wait time and also improve the customer satisfaction. First, to better understand the patient flow, we will show you the flow through the clinic has as of today, the whole process map, and how we improve it by good recommendations like pooling or even buffering through this process.
Hello, my name is Bruce Peel, and I'm going to talk about the different areas of customization for an urgent care clinic. These will also be the areas that we then look at improving in once we start applying metrics to those processes. We start with the scheduling process, in which technology has made online scheduling easier than ever, but that being said, there are still times in which having in-person staff is beneficial. Supply versus demand has huge impacts on our staff, resources, rooms, lab technology, etc. And this is largely dependent on what type of community we are providing care for, a 100-person rural community or a population of 200,000. Special circumstances such as the pandemic also have drastic impacts on what kind of care we provide in an urgent care. During our COVID-19 outbreak, a lot of urgent cares would have patients simply drive up to the clinic, get swabbed, and then be called later with their results. This reduced the amount of rooms needed, nursing staff, and other processes, and was still able to provide care. Similarly, this was also when the advancements in telehealth were drastically improved as well. So patients were able to be seen by their doctor, but without taking up rooms, resources, and not exposing further individuals to the spread of infection. And this all goes into the big question of urgent care in any process, really, which is the quality versus quantity trade off. You could see 100 patients in an urgent care clinic, but are you still delivering quality care? Conversely, if you only see 5 patients, try to deliver the best care you can, but are you now producing enough to still make your clinic viable? Next, I'd like to touch base with our inventory, which for an urgent care is the patients we move through each day. And as our textbook outlines, there are 5 reasons in which we would hold inventory. 2 very common ones for urgent care, including seasonal inventory, such as the respiratory season we see during the winter months, in which we see an increase in respiratory illness and viruses. And number 2 is the buffers that we can use, most notably for an urgent care would be lab. This allows doctors to still evaluate and see patients while other patients are getting their labs drawn, swabs completed, x-rays done, and not having to sit in waiting rooms. And we will start applying numbers to those buffers in the upcoming slides.
Hello, my name is Noel Young, and I'll be presenting the current workflow at the urgent care clinic, or more accurately, our baseline that we are looking to improve. First, we estimated the number and type of resources that are used at each process step. This is documented in the resources table in the lower left-hand corner of this slide. After that, we estimated the service time that we felt each process step would take. Second, understanding that urgent care clinics are inherently variable, we ran some simulations to establish the standard deviation of both the service time and the inter-arrival time. We felt that these numbers accurately represented the variability in many urgent care clinics. Turning your attention to the workflow diagram itself, we anticipated that 15 patients would arrive every hour. The workflow process itself is relatively simple. The patient arrives and checks in. Here you'll see that the patient experiences an average wait time of 0.43 minutes. From check-in, they are routed to either the lab X-ray or to the waiting room. We estimated that 50% of patients would need to go to the lab X-ray room. Note that in our calculations, the lab X-ray was the bottleneck of this entire process. Next, patients experienced either a 4.4-minute wait or a 2.1-minute wait in the lab X-ray or waiting room, respectively. From there, the patients go to nurse rooming, where they will get basic information taken, such as vitals. Following, they go to a second waiting room where they wait to see a doctor. This waiting room experiences very high average wait times of 57.8 minutes, primarily due to the high level of variability with the doctor's service time. To summarize, we discovered that on average, the total flow time of a patient is 91.84 minutes, of which 64.84 minutes are the patient waiting. Definitely lots of room for improvement here. To look at these issues a little deeper, I will pass the presentation off to Noah. Thank you.
Hi, my name is Noah Hugenine, and I will be discussing the key issues and potential improvements with the current process. One of the biggest issues is the high utilization across medical staff and equipment. There are inherently a small number of medically trained professionals in the workforce, meaning the labor resource is restricted and difficult to increase. The same applies for medical equipment and labs, where there's limited space at these sites to introduce more capital resources and staff to use them. Another issue is the unpredictability of arrival time and patient volume. Some sites can mitigate this by offering online check-in services, which stagger exam times to help staff prepare prior to patient arrival. However, this only works for routine visits and doesn't help to alleviate patients with urgent issues that are prioritized, which reduces the inter-arrival time and strains resource utilization. This also introduces high variability across the process, as exam time and diagnosis can be longer than anticipated depending on the patient's medical concern. Lastly, there is some redundancy found in triage, where the patient is often found repeating their medical concern multiple times with different staff members, once at check-in, then again with the nurse, and finally with the doctor's evaluation. This repetitiveness adds additional time to each activity, which increases the overall process time and subsequently the waiting time. The first improvement is to pool staff resources. Pooling would specifically be beneficial in the triage process. When all the staff are aligned with a medical concern, the process time can be reduced as staff are prepared on the required steps for proper evaluations. This mitigates process variation and improves activity times, which reduces patient wait time. It's also beneficial with families where members can be evaluated together rather than separately. Another improvement is cross-training. We see that staff don't often have the same training, which can introduce longer wait times, as certain procedures during evaluation require specific staff members to perform it. By enabling staff to take on more responsibilities, patients can be addressed sooner and the wait time can be reduced. Cross-training decreases utilization of labor resources and improves overall process capacity and process time.
Hello, my name is Shivkumari. I'll be discussing about the numbers, what we have discussed about the improvements in the previous slides. Okay, in this slide, I'll be talking about the pooling, which is an opportunity to go further without increasing the head count. So, looking at the numbers on the left hand side, one of our bottlenecks was lab and X-ray in the current process, and by improving the process, and we are coming up to the number capacity where we can increase the patients where we can process. And on the right hand side, our next bottleneck point is the doctor's evaluation and improving our variability and focusing on the improvements, and our wait time for the doctor's evaluation has decreased, and we can see there is an improvement of 72%. This slide illustrates the effect of cross-training staff across the process steps, especially at our high impacted bottlenecks. Before cross-training, the numbers, whatever it was there on the left hand side, after the cross-training, the numbers are shown on the right hand side. There is a lot of improvement with respect to the process time, and at the same time the utilization has reduced, where it shows like there is an opportunity for us to serve the more patients.
So in conclusion, demand in the medical field is borderline unpredictable, which leads to key issues such as high utilization and variability. To mitigate this, we believe encouraging cross-training and pooling staff resources will help reduce wait time and process times. From this class, we understand the importance of reviewing each resource capacity, both labor and capital, to understand the overall process's capacity. In addition, although variability is inherent in the medical field, it can be mitigated with the help of pooling and maintaining utilization at reasonable levels.